So the first thing I'm going to do is come in and put my hands on top of the iliac crest and press down. Okay, so I'm right on the top. And then my thumbs are going to land right on the ASISs, okay, anterior superior iliac spine. Now, when you're treating people who have lumbosacral problems, it's going to be very important to be able to identify if the iliac crests are symmetrical. And you're going to need to be able to do that in standing, in sitting, in supine, and in prone. So it's really important. Now remember, my left eye is dominant, and I automatically go to having my left eye over the person's body. So I have iliac crest here, and then ASISs. Now, the ASIS is going to be quite broad. And so what you want to do is come down underneath and come up against it, just like we did for the PSISs. If you remember in standing, we again found the iliac crest and then came down to those dimples and then came up underneath and pressed up. I do the same thing with the ASISs. So iliac crest, ASIS. Again, you're going to be looking for symmetry. You're going to be looking for symmetry both anterior, posterior, and superior, inferior. Those are all going to tell you things about the ilia and how they relate to one another. Okay? So there's ASIS. Now the AIIS, we're going to kind of use our hook of hamate pisiform trick. You're going to put the IP joint right on the ASIS, come in inferior and medial, and you'll be close to the AIIS, but it's going to be a little bit deeper. Okay?
So use your thumbs?
Yes, I do. Somebody Benjamin's here this time. There you go. So we're at ASIS. Are you flash? Okay, on her it was actually pretty easy to locate. So then I'm on her AIIS now. Okay? For some people you're going to have to dig a little bit further, and that's why sometimes it's easier to use the thumb as well. You're also, so what muscle attaches to the AIIS?
Sartorius. Yes? Or is it AIIS?
ASIS.
A lot of muscles.
The quadricep, one of the quads attaches to the AIIS. I'm blanking on Sartorius.
No,
ASIS. Okay. Okay. So I think of it as a quad attachment. Okay, so that's why you would want to palpate it. Your patients generally won't. Okay. Now, the iliac fossa, for those of you whose fingernails are not very short, I do not want you to try this because it's not super comfortable for your patient to begin with. And if you have long nails at all, I don't want you to practice it.
Sorry, Rachel.
So for this is going to be really important because you will have patients who will have spasms of their iliopsoas, and you want to be able to palpate the muscle belly. And so you need to be able to go in and palpate that. Again, you need to go slow and really just change the angle of your hand first before you apply a lot of pressure, because if you just go, the person's going to go like this, okay, and you're never going to get back in there. And for some people, it's really important that you be able to treat that muscle because that's the only thing that's going to make them better. So when I talk about the iliac fossa, I'm talking about the anterior surface of the ilium. Okay? Remember, there's all person between the top and this. Okay? I didn't tell you what you were signing up for, did I?
Great.
So you find the ASIS, and then you're going to just go in just a little bit. Now, this one I am going to palpate through close. You doing okay? So I'm going to move my fingers just a little bit as I go in. You can see that my hands are fairly perpendicular. Okay. As soon as she gives me some resistance that I'm pressing too hard, I'll back off a little bit, because if I try to push through a muscle tightening, that's not going to be a benefit to anybody. Okay? You are being a trooper. Good job. Now, if you get... okay, you can't laugh. So you're starting to go, whoa. So, if you go too medial, now you're fighting organs, okay? So that doesn't work. So you really want to be just a little bit medial to the iliac crest and work your way down, okay? I was probably about halfway there, right? So, but it's, again, it's a slow process when you go down for that, okay? Now, the pubic symphysis is next. For I would say more women than men. But just clinically, I have no reason to believe that. In my own experience, if I have people with pubic symphysis dysfunction, it's more women than men. It's not that men can't have it happen, but it certainly seems more common in women. What can happen is if the ilia, for some reason, childbirth is the one that comes to mind, the ilia are going to separate, and when they come back together, they can come back together asymmetrically and cause a boatload of anterior pelvic pain, and it's because the pubic symphysis is no longer aligned. So it's really important to be able to palpate that structure. We're going to come down on here, and we're going to see if one is higher than the other. Okay? There's a super easy treatment for it if that is the problem. You want to know that that's a problem before you treat it. Okay? But you'll have patients who have maybe seen 3 other physical therapists, and they come to you and they're feeling a little crabby about life, and you go in and you go, oh, this is a pubic symphysis dysfunction, and you can clear it up within a day. I mean, it's one of those things that if you're not afraid to palpate the pubic symphysis, you can really help people in some really meaningful ways. Okay? So before I would ever palpate that, I would actually bring in our clinic we had like a tabletop spine, and I would explain to someone why it was important to palpate it. And then typically what I would do one of 2 things. So if it's a female patient, what I would do is say, I need to palpate this front part of your pelvis. So what I'm going to do is start with my hand like this. I'm going to work my way down until I feel that bone. Okay? The other thing you can do is ask the patient to do that, to find that bone for you, and then you come in and palpate it. Either way is completely appropriate, and I'll show you both ways.
Should we do that if it comes up on the practical?
Yeah, either one is fine, depending on who your partner is. You know, and 2 of you will have to palpate it on the exam, right? Because
should we go through the educational process?
Oh, no. Okay. I'm sorry. Yeah.
Wheel of skeleton.
Yeah. So Billy, I need to palpate the front of your pelvis, and so I'm going to bring my hand down until I feel that bone, and then I'm going to put my thumbs there so I can see if they're lined up correctly. Okay? So I'm starting with my hand right over her umbilicus, and I'm working my way down. And do you feel that bone right under my hand? So I'm going to come in here, and I'm looking to see if it's level. Okay? So that's one way I would do it, and that's honestly how I would do it most commonly if I were palpating it on a woman. So on a man, generally I'd say, I need to feel this bone in the front of your pelvis. What I'd like you to do is find it for me and do the work for me. Okay? So what I want you to do is start with your hand here and work down until you feel a bone. Okay? So are you left or right-handed? Okay. So go ahead and start here and just press down with your fingers until you get to them. Do you feel it?
Yep.
There you go. Thank you. And then I would come in and palpate it. Okay? So those are 2 strategies that I've used to palpate a structure that's relatively sensitive. It is a sensitive enough area that I think it warrants getting consent again. Okay, making sure someone is okay with that. Do you have any other tricks you use other than those 2? Okay. All right, so that's pubic symphysis. Inguinal ligament is going to go from the pubic symphysis to the AS-IS. So you essentially know where it is. It's a ligament that's going to run in this direction, so you're going to palpate oblique to that, and you're going to feel that ligament. That ligament is a very common place for people to have inguinal hernias. Okay, so again, if someone has anterior groin pain, you'll want to rule out. We don't treat hernias, but you may want to rule out that there's a hernia. Okay. The other thing is that just inferior to that, there's going to be a row of lymph nodes. So you may also want to be palpating that structure, use that as a landmark to find the lymph nodes. Okay. There's also what's called the femoral triangle, which I think is on the next slide. Oh, no, it's probably in the hip. We're going to be palpating nerve, artery, and vein that also is just inferior to the inguinal ligament. So it's a landmark for a lot of structures. It's not a ligament that's going to be stressed or strained or torn, so you wouldn't palpate it for integrity, for example, other than potentially for the hernia. Okay? The abdominal aorta should be right in the middle, and I've got a figure for you. You see it's really big. And you're going to palpate for a pulse, and it should be super, super strong. And I actually don't feel bellies.
I'm done.
How low below the
So
pelvis?
I I am right, her umbilicus is right here. So I'm just above it. Okay? When you lie supine, you will feel it and it'll be almost bounding. Okay? Because it's such a big vessel. Now, the linea alba is again a structure that is important to palpate for women's health. Now, I know that not all of you are going to go into women's health, but if you're in outpatient orthopedics, you're going to treat people who have had a baby. The linea alba is where the rectus abdominis splits to allow a pregnant woman's belly to expand. Okay? And you can actually get a diastasis of the linea alba. Did you learn about did you have a cadaver?
Our demo for our for anatomy, we did diastasis recti and a couple other things.
Okay, so for when you're treating someone postpartum, you'll actually teach them ways to regain their abdominal strength, and one of the things that you'll want to look at is their linea alba and look to see if they have a diastasis. So you'll actually have them do a crunch and see if that gets greater. We actually had a patient or a student in the very first class, a male student, who had a huge diastasis of his linea alba. It was really cool. He didn't think so, but we did because it was really deep. So for that one, you're going to be palpating right along the middle, and then I'm just going to have you curl up just a little bit. Just lift your head and shoulders up, okay? And hers is nice and intact.
So would it be a divot?
Yes. It'll be a fault line. So the skin will come and then it'll go down. But it's not like a six-pack. That's just fascial tightness that gives us that, well, gives us, I use that word us. I've got a 12-pack or a small keg. It gives us that definition is the fascia. A diastasis of the linea alba will actually be 2 centimeters deep or 3 centimeters deep. I mean, it can be quite deep. Okay? So let's go ahead and do these anterior structures.
Just got cats on the net.